Dear Chairman, moderators, and well-respected colleagues, it gives me great pleasure to stand before you and present our field of research in Nocturia. And we would like to present that I have my disclosures up there. In terms of the definition of nocturia, we know that it's waking at night to void. We know that it's also highly prevalent and extremely bothersome. We've seen data that reflects that. We also currently classify it as a storage symptom in lower urinary tract classification network. And we know that the clinically significant threshold is greater than 2 voids per night that patients tend to report the most bother at. In terms of the associated conditions and impact, we know that there are relationships with hypertension, with congestive heart failure, with mental and sleep awakening and fragmentation, as well as physical well-being and performance. We know that Luts includes many symptoms, including frequency, urgency, nocturia. We know that nocturia can be overlooked or combined with diagnosis of overactive bladder or benign prostatic hypertrophy, which can also be considered other Luts if we would like to separate nocturia as a predominant symptom. There's a paucity of US data that links specific nocturia diagnosis to work performance away from overactivity or benign prostatic hyperplasia. We sought to exploit these differences and show them. We would like to distinguish nocturia as a distinct clinical entity, and we find that it's fundamentally important to understand the etiology before prescribing treatments, as the panel has mentioned several times this morning. So in terms of specific aims, we wanted to quantify the number of patients that are diagnosed with nocturia versus other Luts. We also wanted to compare their demographic considerations, various sleep parameters, daytime napping, as well as the impact on work productivity and impairment as surrogates for overall performance. And our hypothesis was simple. We thought that if we had precise nocturia diagnosis, this may impact sleep disturbance, work productivity, or other evaluated parameters that we looked at. So in terms of our study design, we looked at the Adelphi Lower Urinary Tract Symptoms Disease-Specific Program, which is a US-based point-in-time survey. You could have had a single diagnosis or a combination of diagnoses. Overactive bladder questionnaire was used as one of the outcome measures. The Nocturia Impact Diary was also used. The Work Productivity and Activity Impairment Index was also used. And we have groups that are basically categorical. We had non-nocturia group or other Luts on one side and nocturia group, and that way we wanted to tease out the differences between these. So how did we do it? We had patients complete a patient record form. Physicians completed a patient record form, and over the next 14 consulting patients, they decided which diagnosis would be most suitable for them based on their clinical presentation. In terms of the patients, they completed a questionnaire, and they eventually were stratified into the non-nocturia group and the nocturia group, 776 without nocturia and 334 with nocturia, 148 physicians, and 1,110 patients. In terms of results, first I'll pull up the demographic information. Without belaboring any points here, we can see that all the statistical values are non-significant, so the groups were comparable in terms of age, ethnicity, education level. In terms of the patient-reported outcomes, we look at nocturia sleep significance and note that it's significantly higher in terms of mean nightly voids as well as daily naps. Now, these are values that are significant to p of less than 0.05, but in terms of the mean nightly voids, it was p is less than 0.0001, so highly significant there. In terms of the additional burden of nocturia, waking up to urinate with less than 3 hours of sleep, again, very highly significant. Tired during the day, highly significant, and bothered by nighttime urination, the most highest significance. In terms of severity and impact, we saw some interesting findings. In terms of looking at our specific surveys, we note that in terms of symptom severity, in terms of nocturia, it actually does go up with the very highly statistically significant value there. However, in total health-related quality of life, it seems that OAB and BPH seem to have caused a greater problem, and we'll try to address those points later. In terms of daily activity, total impact, overall work impairment, and activity impairment, all statistically significant differences with nocturia patients and diagnosis. In terms of interpretation, we were able to we were able to interpret that a significant portion of Luts patient can be categorized as nocturia patients. Nocturia can either coexist or be independent of Luts. The nocturnal polyuria syndrome could be a part of it or may not be a part of it. It's quantifiable, it's biologically plausible, and we're demonstrating that we have statistically significant values. Additionally, we know that there were links with accompanying nocturia diagnosis, including hypertension, diabetes, cardiovascular disease, and the other things that our co-presenters mentioned this morning. We know that it also affects multiple domains of quality of life. So in terms of conclusions, the take-home messages here are that appropriate nocturia awareness, discussion, and diagnosis is pivotal to comprehensive evaluation. We do not recommend jumping to pharmacotherapy or evaluating anything outside of the treatment algorithm paradigm. We advocate making sure that the etiology is determined first, all conservative measures are taken, and then we can consider the appropriate paradigm. So eliciting the history and having the knowledge of nocturia burden can prompt physicians to systematically evaluate potential causes. We know that domains of life are affected, we mentioned this, that domains are affected in numerous different areas, and it causes strains on patients, the providers, the payers, the workforce, and the economy. So we would like to do future studies that address gaps in knowledge between nocturia diagnosis and associated economic burden. Thank you very much.
Thank you very much. Questions from the audience?
You seem to be saying that we should take a history from our patients and evaluate them.
I think so.
I'm not sure what this study adds, because we kind of knew that, didn't we?
Well, in terms of the diagnosis, it's important to tease out the nocturia symptoms as far as what the clinician is asking about. We've noted that there are specific questions that may or may not be addressed during clinical evaluation, and it depends on how you take the history and physical. So some people will take a very detailed history and physical, maybe Professor Weiss or Dr. Blavis, and other people will kind of be a little more broad. Surgical.
But my question is coming into the same situation you are talking about. To pinpoint it to nocturia, I think all the other real issues like heart pressure problems, and we have seen that in tiredness of the day, you pull it into nocturia as a treatment, and I think we have to be careful of that. So it is pulling it to one symptom, and we are not supposed to really treat a symptom. We have to differentiate for the patient what is his major course. But there's a question. I'm sorry that I didn't see you right away.
I think it's really important to understand the impact of nocturia on patients. My question for you is, did you solicit history on primary sleeping disorders? Because part of the question is the poor sleep, the poor work, and then following day a result of the sleeping disorder, for which nocturia is also a symptom of sleeping disorders. So how can you tell if it's really purely the nocturia or the actual sleeping disorder that's causing the symptoms?
No, thank you for your question. It's an excellent question. Actually, it's the chicken or the egg scenario here. We did not take sleep parameters into account during that particular exercise. However, it's something that we are looking at in greater detail in the future. And to your point, Professor, we always advocate for stratifying patients and determining the etiology of the nocturia and absolutely treating those primary causes first and then coming to the appropriate pathway.
Thank you very much for the presentation. We come to the last one.
Thank you.